Assalamu alaikum to everyone. Welcome to the channel of Pharmacology Medicine. Today we'll discuss about adrenocorticosteroids and we'll discuss about the biosynthesis of adrenocorticosteroid, pharmacokinetics and pharmacodynamics of the steroid, and also know the clinical use of steroids. And also we discuss about the uh, steroids indication is steroid common indication and what are the steroids we now used or maybe the classification of steroid we can discuss, and the synthetic steroid which are useful in different diseases we can discuss it also. And today's discussion will be also on the pharmacological of steroid. So if we start the steroid biosynthesis, steroids are synthesized from a precursor that name is cholesterol. The nucleus of the steroid name cyclopentanoparahydrophenanthrene. How the steroids are synthesized in our body? Steroids are synthesized mainly from the adrenal cortex. Adrenal cortex is three layers: zona glomerulosa, zona fasciculata, and zona reticularis. From the zona glomerulosa, the mineralocorticoid are synthesized. From the zona fasciculata, the glucocorticoid are synthesized, and from the zona reticularis, the androgens are synthesized. How they are synthesized from if we discuss about the glucocorticoid, how glucocorticoid are synthesized. Glucocorticoids are synthesized by the action of hypothalamic pituitary adrenal axis. This hypothalamic pituitary adrenal axis, in certain situations such as stress, hypovolemia, or sudden hemorrhage or some infection, the hypothalamus is stimulated to release the corticotropin releasing hormone. This corticotropin releasing hormone stimulates the anterior pituitary to secrete ACTH or adrenocorticotropic hormone. These adrenocorticotropic hormone stimulate the cholesterol, which stimulate the zona fasciculata to release the glucocorticoid. How the cholesterol synthesized glucocorticoids. Cholesterol at first converts into the pregnenolone. From the pregnenolone, 17-hydroxypregnenolone develops in case of glucocorticoid. From the 17-hydroxypregnenolone, it develops 17-hydroxyprogesterone. From the 17-hydroxyprogesterone, 11-beta-deoxycortisol is developed. And from the 11-beta-deoxycortisol, it converts to cortisol. And cortisol is the main hormone. It is the main natural hormone for glucocorticoid, and its synthetic name is hydrocortisone, which is used in several indications in nowadays. How the mineralocorticoid is synthesized? Mineralocorticoid is also synthesized from the cholesterol. This cholesterol is stimulated by angiotensin 2. This angiotensin 2 comes from the activation of Renin-Angiotensin-Aldosterone system. This Renin-Angiotensin-Aldosterone system is activated by any hemorrhage, any hypovolemia, where there is a angiotensinogen which comes from the liver. This angiotensin is stimulated to convert the angiotensinogen to angiotensin 1 by renin. Renin comes from the kidney, and it converts the angiotensinogen to angiotensin 1. This angiotensin 1 is converted by the angiotensin converting enzyme to develop the angiotensin 2. This angiotensin 2 converts the cholesterol at first to pregnenolone. This pregnenolone is converted into progesterone, and this progesterone is converted by 11-deoxycorticosterone. This 11-deoxycorticosterone is converted into aldosterone. Here different enzymes are act here and converts the cholesterol to become aldosterone, and this aldosterone acts on the collecting duct and some early part of the distal convoluted tubule to reabsorb the sodium, and it wastes the potassium and hydrogen also. So there will be a increased rise of blood volume due to sodium retention and sodium and water retention, and sodium and water retention turns the hypovolemia into hypervolemia, and the ECF volume will be rise, and it's a one type of compensatory mechanism. and this is one type of this is the biosynthesis of mineralocorticoid. Androgen also comes from the cholesterol. From the cholesterol, how androgen are synthesized? From the cholesterol there is a pregnenolone are synthesized. From pregnenolone 17 hydroxy pregnenolone are synthesized. From the 17 hydroxy pregnenolone testosterone are from the 17 hydroxy pregnenolone uh, dihydro, we said it, dihydroepiandrosterone is synthesized, DHEA. This DHEA is converted to testosterone, and this testosterone converted into the estrone and estradiol. So this is the biosynthesis of steroid. Now we can talk about the circadian rhythm of steroid. Circadian rhythm means steroids are fluctuates in our body. The level of steroids in the blood is fluctuate in any time in our body. The steroid levels is peak at the awakening time, and by the time being it becomes decrease. It also decrease at the evening level, and it also peak in the early morning. It also becomes less at night. And this is the circadian rhythm of steroid. So steroid level or fluctuates in our body in different times. Okay, now we will discuss about the pharmacokinetics of the steroid. Pharmacokinetics of steroid, and mainly the glucocorticoid. We will discuss about glucocorticoid in this video. Glucocorticoids, cortisol, the half-life of cortisol is 60 to 90 minutes, and this cortisol is bind with the cortisol binding globulin mainly, and 5% with the albumin. Cortisol binding globulin may rise in different condition. If we give exogenous steroid in any kind of people, the cortisol binding globulin may rise, or it may also rise in uh, hypothyroidism, and it may also rise by using some drugs also. Cortisol binding globulin is decreased in hyperthyroidism. So the glucocorticoid, mainly cortisol, binds with the cortisol binding globulin. Cortisol half-life may increase by increases dose. Glucocorticoid are metabolized in the liver. It is a glucuronidation mechanism by through the glucuronidation, and one person becomes unchanged form in the urine. It is excreted in the urine in unchanged form. What will be the pharmacodynamics of this steroid? Pharmacodynamics of the steroid. If we start the pharmacodynamics, steroid hormone present in the cytosol of a cell. The glucocorticoids in the blood first bind with the cortisol binding globulin, but when it enters into the cell, it becomes alone and enters into the cell cytoplasm. In cell cytoplasm, steroid receptor is bind with two types of heat shock protein 90. This heat shock protein 90 makes the steroid receptor stable. When the steroid receptor binds with the steroid, the heat shock protein 90 becomes dissociated and makes it unstable complex. So steroid bind with the steroid receptor makes the steroid receptor complex, which is unstable. It becomes stable and dimerized to form become dimerized, and then it enters into the nucleus where it binds with the GRE, the glucocorticoid receptor element, and make a transformational change, or a transcription occurs by RNA polymerase. So it is converted to at first pre-mRNA. The mRNA comes from the mRNA will be synthesized from the pre-mRNA, and this mRNA helps in the protein synthesis. At first transcription occurs, then translation occurs, and then protein will be synthesized. These proteins gives the main different types of response for steroid. Now the steroid's pharmacological effect. The steroid has different pharmacological effect. Firstly, it has anti-inflammatory, anti-allergic, and immunosuppressive effect. Second, there may be permissive action of steroid. Third, steroids has different effects on metabolism. Fourth, steroid has other effects. In other, there are very different effects of steroid. At first, we will start today about the anti-inflammatory, anti-allergic, and immunosuppressive action of the steroid. What is the anti-inflammatory action of the steroid? Steroid increase the neutrophil release from the hematopoietic stem cell to the blood and to the blood and increase the neutrophilic action into the blood, and it migrates the neutrophil from the hematopoietic stem cell to the blood and also to the tissue when this tissue are inflamed. So steroid increase the synthesis of neutrophil. One kind of thing is it, and the second thing, steroids migrate the lymphocyte, eosinophil, basophil from the blood to the lymphoid tissue. Steroid turn the lymphocyte, eosinophil, basophil to go to the lymphoid tissue from the blood. So this is the one kind of inflammatory action of steroid, and other inflammatory action is steroids inhibit the rate limiting step of inflammatory action. That's why the prostaglandin and leukotrienes are not synthesized. How this occurs? We know about the how the inflammatory mediators are released from the cell membrane. Phospholipase A2 converts the cell membrane into the arachidonic acid. This arachidonic acid has two pathways. One is cyclogenous pathway, one is lipogenous pathway. From the cyclogenous pathway, the prostaglandins are synthesized, and from the lipogenous pathway, the leukotrienes are synthesized. The steroids inhibit the rate limiting step of this pathway, so they mainly inhibit the phospholipase A2. So that's why prostaglandin leukotrienes are not synthesized, and the inflammatory cascade, inflammatory mediators are not released, and it helps in to prevent inflammation, and it's one type of anti-inflammatory action of the steroid. Steroid has also some anti-inflammatory action by stabilizing the lysosomal membrane. It also stabilizes the mast cell, and this mast cell cannot release the histamine. This is the one type of anti-inflammatory action of the steroid. If we talk about the anti-allergic action, how anti-allergic action is mediated by steroid? Steroid anti-allergic anti-allergic effect produced by stabilizing the lysosomal membrane. Secondly, it stabilizes the mast cell, so mast cell cannot release the histamine. So histamine cannot go to the inflammatory area and does not produce bronchoconstriction, does not produce capillary permeability, does not increase the does not increase the does not causes the edema, does not produce does not transudate fluid. So it inhibits the mast cell. That's why mast cell does not release the histamine. So histamine cannot do such type of thing, that is increase capillary permeability, increase vasodilatation, or bronchoconstriction. So these features are not produced by the releasing of histamine from the mast cell. So mast cell may be stabilized, or mast cell may be controlled by the steroid, and mast cell may be not degranulate. If we say it, mast cell is a one kind of cell in which histamine, 5-hydroxytryptamine, and also heparin are coalescence in a nutshell. So when mast cells are degranulated by certain anaphylactic reaction or by type 1 hypersensitivity, in first exposure there will be no release of inflammatory mediators, but the post exposure of same allergen or by some pathogen, and the mast cells are degranulate to release these chemical mediators. So when the steroids are given, steroid does not help the muscle to granulate, and so that's why the histamines are not released. And if histamine are not released, so these are the deteriorating action of histamine, which do not produce by using steroid. So it is the anti-allergic action of steroid. How immunosuppressant action of steroid. Immunosuppression action of steroid is occurring in one type of disease uh, where there is a hyperimmunity or immunity exacerbate in types of one disease in which we called it GBHD, graft versus host disease. In this host, there is a key there is a chance of hyperimmune condition. So if we give steroid does not help to produce antibody formation there, and there will be no antigen hypersensitivity over there, and also steroid reduce or delay the revascularization on host cell. So these are the immunosuppressive action of steroid. So now we discuss about the effect of steroid on metabolism, or effect of glucocorticoid on metabolism. In carbohydrate metabolism, glucocorticoid helps to synthesis or helps to release glucose from glycogenesis or from the neogluconeogenesis, where the glucose are produced. These glucose peripherally are not utilized by the muscle, so the blood glucose level may be increased in case of giving steroid. Mm, on protein, steroid has a protein degrading capability. It degrades the protein from the muscle, so muscle becomes atrophied, and proximal myopathy may be developed, and muscle atrophy may be developed, and muscle mass may be decreased, and muscle becomes thinning, and muscle power become also lost in giving steroid. If we see the metabolism of what is the role of steroid on fat metabolism. Steroid increase the lipogenesis, that's why it increase the synthesis of different types of lipids, which these lipids are peripherally deposited in different sites of our body. It may be deposited in our shoulder, in our neck, in our abdomen, and different features are developed for developing of these lipids, synthesis of these lipids. And sometimes there may be synthesis increased synthesis of LDL and decreased synthesis of HDL by the steroid, and which causes a change in the blood vessel and leading to atherosclerosis. This atherosclerosis may turn into the angina, and sometimes in myocardial infarction. Stroke may be occurred due to atherosclerosis. These are the features of steroid on different metabolism of our body. Now the permissive action. Permissive action is defined that some presence of glucocorticoid in our body helps to act different hormones, or helps to act different hormones to give response in different system. If we say the glucocorticoid levels are low in our body, then there will be low of synthesis. There will be less synthesis of epinephrine and norepinephrine. And and their response in the vascular smooth muscle and bronchial smooth muscle may be diminished. Or if your glucocorticoids are present in your body in a certain amount, then it causes the release of epinephrine and norepinephrine from the adrenal medulla, and it helps their responsiveness to their vascular smooth muscle and bronchial smooth muscle. And in certain region in bronchial asthma, glucocorticoid have some anti-inflammatory effect and also some permissive action. Anti-inflammatory effect, bronchial asthma is a chronic inflammatory condition, so steroids by some mechanism inhibits its inflammation and gives the anti-inflammatory action. But if we say how in bronchial asthma the bronchoconstriction is cured by the steroid has no direct role in bronchodilation in bronchial asthma. It has the role of permissive action, how it contributes to bronchodilation in bronchial asthma patient. It helps to release epinephrine or adrenaline from the adrenal medulla, and this epinephrine stimulates the beta 2 receptor in the bronchial smooth muscle and causes relaxation of the bronchial smooth muscle, causes bronchodilation. And if we say the blood pressure become less due to some causes, this steroid has some permissive action by epinephrine, which stimulate the vascular smooth muscle and causes vasoconstriction to increase the blood pressure, because it has role on epinephrine has vasoconstriction property through its alpha receptors. Okay, this is the permissive action of steroid. There are some other effects of steroid. Steroids have different effects on the central nervous system. Steroid produce depression, psychosis in the central nervous system. Steroid produce osteoporosis in bones, and these osteoporosis may be developed due to the hypercortisol, due to the steroid stimulates the osteoblastic activity and also antagonize the vitamin D. So calcium does not absorb to the bone. So calcium resorption occurs and bones become fragile, and the for this osteoporosis pathological fracture occurs becomes any kind of time, and it mainly develops for the postmenopausal women who are taking steroids for rheumatoid arthritis or for SLE for a prolonged period of time. So this such complication may occur by giving steroids. Steroids has some effects on the kidney. Some glucocorticoids have mineralocorticoid activity. When the mineralocorticoid activity is influenced by the glucocorticoid, it reabsorbs the sodium and water retention by the kidney by acting by reabsorb the water and sodium through the early part of distal convoluted tubule and collecting duct, where they reabsorb the sodium and water and increase the extracellular fluid volume and produce edema to different parts of the body, and this edema develops in different parts of the body. So that's why steroid also causes edema by reabsorption of sodium and water through kidney. If a patient is hypertensive this hypertensive patient, if take steroid, this steroid increase the sodium water reabsorption, and this hypertension may develop heart failure. So sometimes steroid is dangerous for health. There are another thing of steroid. When there is hyperglycemia by taking steroid, the insulin are released from the pancreatic beta cell to compensate the hyperglycemia. But this insulin is an anabolic hormone, so it causes the protein synthesis and increase the weight gain. So by taking steroid, we also increase the weight of our body, and it will increase the weight to 1 to 2 months in 2 to 3 kg. There are other features, there are other effects of on electrolytes by the steroid. Steroid may causes hypernatremia, hypokalemic alkalosis, or it's sometimes called metabolic alkalosis. These are the all pharmacological effect of a steroid, which we describe if we describe it along the system. In the central nervous system, what will be the pharmacological feature? What will be the pharmacological feature in GIT? What will be the pharmacological feature in kidney? What will be the pharmacological feature of steroid in on electrolytes? These are all the pharmacological effects of steroid. Now we should discuss about the uh, indication of steroid, where we can give steroid. Steroids can be given in hormonal replacement therapy or replacement therapy that occurs in acute adrenocortical insufficiency, or maybe in we can give it addition disease, chronic adrenocortical insufficiency. We also give in secondary cause of the adrenocortical insufficiency due to hypopituitarism. These are the replacement therapy of steroid. Now the therapeutic indications of steroid. In what condition we can give steroid? If we describe it at a glance, you can not remember. You should remember it by telling A B C D E F G H. You can remember by telling this, or by memorizing A B C D E. If we starts A for allergic diseases, where the steroids are giving. Allergic disease means bee sting, allergen exposure, type 1 anaphylaxis, anaphylactic reaction, anaphylaxis, bronchial asthma, different type of drug reaction, we can give steroid. If we say it B, then bones and joint disease comes. Bones and joint disease are bursitis, tenosynovitis, enthesitis, in which steroids are given. The steroids are given also in collagen vascular disease. C for collagen vascular disease. In rheumatoid arthritis, in systemic lupus erythematosus, in mixed tissue connective disease, in polymyalgia rheumatica, we can give steroid. D for drug reaction or dermatological disorder. Different dermatological disorder we can give steroid. What are the dermatological disorder? It may be atopic dermatitis, exfoliative dermatitis. It may be lichen planus. It may be pemphigus vulgaris, scleroderma, where we give the steroid. Also, steroids are giving in eye disease, and E for eye disease, and these are episcleritis, anterior uveitis, allergic conjunctivitis. These are the reason we can give the steroid. Steroids are given in in various conditions, such as immunosuppressive action of steroid can be given through the graft versus host disease, and also to develop the surfactant in hyaline membrane disease, we can give the steroids. So if we tell the therapeutic indications of steroid, you should remember it by telling A B C D E. There are another different type of disease